speak in this course. As Dr. Rashid already mentioned, that this is a very difficult entity, and treating a microbial keratitis with medically with a bug which is non-sensitive to any of your routine antibiotics is really nightmare. And as a cornea specialist, as an infection specialist, you should be aware that what are the options available with you, and when to refer the patient, and when to do surgical management, and what are the is really they are challenging, or just we are thinking they are challenging. So I will touch in my 9 to 10 minutes talk about what are the really incidents worldwide, Indian incidents, what are the few outbreaks which you have encountered in recent 2 years in our community, how we manage them, and what are the options available for us, and what should be the protocol for these MDR bugs. I have no financial interest in any of the products mentioned in my presentation. So I will start my talk with a case with 66-year-old male, and who was undergone SICS with PCIOL 3 months back. Was referred to us by a team of ophthalmologists. This patient was on antibacterial, antifungal. There was no organism at that time, because of they have done even intra-endoscoping, intrastromal antibiotics, intrastromal voriconazole. That was not responding, then it was sent to us. And as everything was done, and the patient was still post cataract surgery, and but the B scan was showing hardly any echoes. We thought only we'll go with hydrating rhinoplasty or patch graft, and we'll see what organism is. So we did the patch graft, we did hydrating rhinoplasty of this patient, and this patient was doing well. This patient is doing well. Now a 1 year old, 1 year follow-up is over, and we revealed the organism of Burkholderia cepacia, which was resistant to all antibiotics. So, like this type of organisms will give you a challenge when you encounter these type of conditions, particularly your iatrogenic cases, status post cataract surgery, status post graft surgery. So, what is MDR? There are few terms which are reported in literature: MDR, XDR, and PDR. Just to make it very simple, that if it is non-sensitive to your routine antibiotics, or maybe basically at least one agent 3 or more antibacterial agents, then you will make it as a MDR. If it is extensive, then you will make it basically to at least 2 group of antibiotics, and when this is not sensitive to any of the group of antibiotics. One more definition which is of very important use for us is a MRSA. What is HA MRSA? What is CA MRSA? HA MRSA is hospital-acquired MRSA, and CA MRSA is community-acquired MRSA. HA MRSA is basically, or a hospital-acquired MRSA is definition by is when infection is identified after 48 hours of admission to a hospital, or you get a definite history of hospitalization, surgery, dialysis, residency, long-term care facility. So this is not for us, this is for systemic care doctors, but definitely is relevant for us also. We use therapies in our routine patients: sulfonamides, macrolides, aminoglycosides, polymyxin-based combinations, fluoroquinolones, cephalosporins. That is our routine teaching. We have been taught to use all these medications in our microbial keratitis patients, and we definitely should do all these microbial keratitis patients microbial workup to see the culture sensitivity. That is helpful to manage our patient in a more scientific and more stepwise manner. But resistance is there. So there are many papers. Since 10 years we are seeing, maybe more than 10 years, we are seeing emerging resistance to every antibiotic, because bugs are more smart than us. Whatever antibiotic you give them, they will develop resistance with any other antibiotics. We develop 4 generations fluoroquinolone. There are reports of 4 generations fluoroquinolone resistance. We develop resistance to all quinolone, whichever you offer to them. Develop which are you seeing the sensitive drug for MRSA is vancomycin. Now you are seeing VRSA. Now you are getting linezolid. Now you are getting LIC, LRSA. Now everything is, whatever antibiotic you give, they will develop resistance to that antibiotic. So in this paper you can see, this is not a recent data. I will show the recent data in my next slides. This is the data from 91 to 97. You can see that insensitive mouses. The resistance is increasing from 3 to 70, 25% to 31%, 34% is not remarkably increasing in these 91 97, but definitely slowly resistance is increasing. And the susceptibility of organisms is decreasing within keratitis and of hematopoietic participation in from 93 to 2001 paper, as you can see in this paper by MHF et al. This is our LVPI data. Yeah. So this is, I will discuss about three most important organisms which we have encountered resistance, and this is one of thesis subject from my fellow Dr. Bhupesh Bagga. I concept from him that this is the data from 3 years. We encountered 193 cases of MDR pseudomonas, and don't get surprised, don't get so much you can say disappointed by the data 193, because of two major epidemics occurred during this. That's why the data is so much showing so much number. So all patients are mostly 58% of status post ketoplasty, 7% status post trauma, and 25% patient of ocular surface disease. We managed medically 173 patients, but 20 patients undergone surgery. Out of them, 17 diabetic ketoplasty, and 3 was so bad that we need to do evacuation. Out of them, the sensitivity pattern, if you see of MDR pseudomonas, most common antibiotic sensitivity is cholesterol and imipenem. Piperacillin, tazobactam are sensitive, but definitely the best antibiotic. So based upon this, we made a policy that for MDR pseudomonas the best drug is colistin or imipenem, but definitely you should go for sensitivity because few patients are sensitive to your ciplox also. This is the trend of MDR pseudomonas in our institute. From 2008, 2009, 2010 it was increasing, but 2011 and 12 when the epidemic occurred, it was almost reaching to 90 cases per year. And 2013, by God grace, it's going down again to 40 and stable as come to 2010. It's a resistance pattern. If you see from 2009 to 2012, 49% of these pseudomonas works are resistant in 2009, while in 2012 they were 70. So we did study in 2006 2008 about MRSA and MSSA. We collected 199 cases of Staphylococcus growth, and we see the trend of increasing resistance year by year. And the good thing is that MRSA versus MSSA, clinically they are not very different, but sensitivity wise, if we said that you see the getafloxacin having nearly equal sensitivity in both MRSA and MSSA. ORSA is oxacillin, which is commonly used for this type of test. But getafloxacin is the better drug in case of MRSA. But vancomycin, if you see the 100% sensitivity, the 0% resistance encountered in MRSA, that is a good drug still. So RS is sensitive to vancomycin. One outbreak of MDR generally, MDR, Burford-Davies asphyxia, which I think AIUS also sent a warning about that epidemic. This was referred from a single surgeon, and it was a 22 eyes with clear corneal incision, and he presented after 99.5 days approximately. These all 21 cases, like we saw all these cases around 3 cases per day, these type of cases, and they all are resistant to all antibiotics except meropenem, piperacillin, imipenem, and average of 44.1 days of treatment with topical antibiotics were over when he came. So no response, and this is all collage of all these patients. If you see the all 21 patients having deep stromal infiltrate, and then localized in the clear corneal superior tunnel, and they're all deep-seated. Patient was on steroids, patient was on all meropenem drops. So we did culture of that particular drop, procarocanine drop, and we did culture of the biopsy which we have taken in all these patients. All species are same, even the genomic studies we did same, antibiotic sensitivity are same. This is histopathology of the same button. You can show the deep-seated infection in this group of patients. And this is a collage out of all patients having undergone pediatric ketoplasty, 2 patients, and all 19 patients have gone patch graft. So management options, I would say the 3 most important things for everybody that should recognize of existence of resistance, prevention of occurrence, and treatment. For recognition, you should have high suspicion of iatrogenic cases. If your patient is being treated for your and you have done surgery, or being treated for your ulcers, or being treated for the graft, and that develop infection, you should be clear that maybe a patient is having resistant bug. Check for antibiotic susceptibility in all cases and to assess the clinical response carefully. Can I have 2 minutes more? So, prevention of occurrence, this is for very important, the most important slide I can say, to avoid injudicious use of antibiotics, follow guidelines of their use, and to treat based on microbial reports. And should be having targeted therapy. It means if patient is having gram-positive cocci, it should not be continued as gram-negative bacilli treatment. Patient is having fungal, even then you are continuing 1 hourly antibiotic therapy. If patient is having gram-negative bacilli, you are continuing with 45 hydroxychloroquine for 1 month. Definitely you are inviting trouble for you and you are inviting trouble for community. I think this is the most important slide you can prevent. But resistant and medical management, there's a few tips which are very important in management. Resistant and sensitive bacteria, clinically indifferent. You cannot say, if somebody is saying that this is a resistant organism, I think this is a wrong statement. They are mostly indifferent by their clinical behavior. Because they are not responding to your routine antibiotics, that's why they are coming in more virulent form. You're saying so much toxin, so much cornea is hazy, large infiltrate, that must be resistant. No. Because the bacteria is like that, the behavior of normal bacteria will be same, but they are different in their management. To start with therapy based on smears, observe carefully the signs of resolution. Carefully means you should see definitely a careful signs of resolution. Check for culture report. If worsening on your standard antibiotics, think of resistance. Get extended spectrum sensitivity also. Extended spectrum means you should not only check for quinolones, not only check for aminoglycosides, you should go for imipenem, colistin, tetracycline, tazobactam for all these bugs. We have presented this paper in New Corneal Congress. The patient is going to colistin eye drop and through to imipenem. This is option for MD organism. I think this is good for you to note it, or I can mail this slide to you, how to prepare your drops from the systemic injections. These are the 4 commonly used medicines which we use. So surgically management wise, we should be low threshold for surgical management because of high virulence only, because you have given enough treatment for these bugs, and by the time the patient presented to you, the organisms can maybe have reached to deeper also. Peritoneal keratoplasty is the mainstay, and look for extensive involvement. One more outbreak, if we should permit, just one more slide. Basically, this patient presented with a clear graph of keratoplasty for fungal keratitis. Developed rejection. We started with intensive steroid and lubricating gel. This patient presented within 3 days with extensive corneal involvement. Other also presented like that. So we cultured that gel, all the drops, and we grew that grew gram-negative bacilli, and both were MDR, means from cornea and lubricating gel. So that was also sensitive to colistin and imipenem. The rest all antibiotics, the rest all inpatient, in turn around 3 patients were resistant to all, that is pan-drug resistant. So for conclusion, increasing trend of oxygen-resistant staphylococcus. In quinolones, gefloxacin and moxifloxacin are better, but should be used very judiciously than others. Vancomycin is drug of choice for MRSA. Increasing trend for MDR pseudomonas infections. You can rely on colistin and imipenem, but early surgical intervention in case of recalcitrant keratitis is the key. Thank you very much.
Thank you, Bhupesh. I think that is perfect.